So the standard of care for FLT3-mutated patients who are not candidates for intensive chemo plus FLT3 inhibitors today is still venetoclax plus hypomethylating agents. We do know that there are differences in between patients who are FLT3-ITD and FLT3-TKD mutated. And it seems that Ven/Aza, at least for FLT3-TKD mutated patients, works really well in terms of response rates and overall survival. So the FLT3-ITD patients seem to be doing significantly worse. And that, of course, brings us to the area which is a very hot topic right now, is the triplets. And the question now is actually whether adding a FLT3 inhibitor to the venetoclax-aza backbone actually results in better response rates and especially relapse-free and overall free survival. So, of course, the triplet regimens are still in the investigative field, but it does seem that the preliminary data is very encouraging, with high response rates, with prolonged remissions and overall survival. But of course, this has to be tested in a larger, preferably randomized trials. At this setting, of course, it's still investigative, but at least at our institution, we do consider that venetoclax and gilteritinib, a second-generation type 1 FLT3 inhibitor combined with venetoclax and low-dose chemotherapy or hypomethylating agents can be successfully used as a bridge to an allotransplantation in both frontline and relapsed refractory patients who are maybe not eligible for intensive chemotherapy, but again, achieving a remission could potentially make them eligible for low-intensity allogeneic stem cell transplantation.